So women's heart is a subject of a lot of attention these days. You have seen it, yeah? The room is almost full, and it has been full yesterday. So it's a very hot topic. I mean, women attract our attention not only because of they are women, but because they have some specific particularities when it comes to their hearts. So thank you for attending this session, which is also... Okay, good. Hélène's gonna...
So good afternoon. Sorry for this problem, and thank you for being here tonight. It's a quite late session, but it's a hot topic. It's as we know, female heart is 50% of the population, so it's a big subject. It's a session sponsored by Edwards Life Sciences, and it is a session, the title is How Does the Female Heart Respond to Severe Aortic Stenosis and Aortic Intervention? I am co-moderating this session with Thomas Modine from Bordeaux in France, and I will show you the names and the picture of the panel. We have experts on echo, on interventional cardiology, we have a surgeon, so we have an excellent panel to discuss all the aspects of this subject. So what do we want you to learn and to have at the end of the session is to learn about the gender specific differences. Do they exist between a woman and a male when patients have aortic stenosis, and how do these differences might affect the treatment strategy? So it's a very important subject. We have also to understand the importance of hemodynamic and durability for the patient perspective, and to discuss the optimal choice for the valve for female patients. So as I said, we have this big panel, and we have a 60-minute session. We propose to have the different presentation and to keep a round table and at the end of the session. And we encourage you to go to the microphone to ask any question related to one of the subjects we will discuss. You can use also the application. So please do not hesitate, because it's a difficult subject, but very important, as you know. And you see here the list of the different presentations, and we'll start immediately. I will not read the subject, the titles, because we will enter in the details. But so the first speaker is Victoria Delgado from Spain, who will discuss about gender differences.
Thank you very much, Hélène, for the introduction, and thank you very much to Edwards for having invited me to this very important topic, because we have not focused that much on the differences, first on how we diagnose patients, whether they are female or male, and also how they respond to the therapy. These are my disclosures, and I just bring you 4 examples of patients with severe aortic stenosis. Here you can see more or less the spectrum that we can find. This is much more perhaps the early phase, with a 59-year-old female who at the moment is asymptomatic, but she has already a peak velocity of 4.5, mean gradient of 45, and an aortic valve area of 0.8. The question will be, do we refer this patient for an intervention or not, an aortic valve replacement or not, or we wait until she's symptomatic? But actually, whether we if we treat the patient, we would like to have this heart later on at the follow-up, because we are doing good to the patient. Here we have a 75-year-old male, more hypertrophic ventricle. The atrium are already more dilated. He has symptoms with dyspnea, has the same peak velocity, mean gradient of 48, and aortic valve area of 0.7. So no question that this patient will benefit or has indicated an aortic valve replacement. This other patient instead is an 86-year-old male, also with dyspnea, but you have the huge atria at the left and the right, and the ventricle very hypertrophic with very small cavity. And even though we measure an ejection fraction that is normal, you have a mean gradient that is low, probably because the stroke volume is small in this small cavity. So this is already more advanced disease, and this one is even also very advanced, 96-year-old female that she arrives with a syncope. So far, We didn't know if she was symptomatic before or not, or she was ever consulting to the GP, but she has a critical aortic stenosis and see the calcification not only of the aortic valve and the mitral aortic continuity, the entire mitral valve. And you wonder whether this cavity can generate such a high gradient. So how they evolve differently, all these patients? One thing that we need to be mindful when we calculate all the parameters that we use in echocardiography to define the severe aortic stenosis is that it's not only the valve. We need to take into account the left ventricle, how much hypertrophic it is, what is the compliance of that ventricle, how stiff is that ventricle in order to fill in during diastole and then generate a good stroke volume. And of course, how is the systolic function? We used to measure ejection fraction, but is this really normal? Or there is also another impairment because of this stiffness of the ventricle? These are all data that we are accumulating now and we are trying to understand better how this disease evolves. We also need to take into account the dimensions of the left ventricular outflow tract and the annulus, because whether that is measured with 2D, that is what we use in clinical practice, or in 3D, we can see differences. And depending on how we measure that measurement, the aortic valve area that we can calculate, it may be smaller or larger, and we can make mistakes. And then we also need to take into account, after the aortic valve, how is the aortic dimension, and understand the concept of pressure recovery phenomenon, that it can be captured with the catheter measurement, but with echo is sometimes difficult. And we have tried to generate other indices, such as the energy loss index, in order to better understand whether that aortic stenosis is severe or not. And think as well as about the loading conditions of the patient and the systemic blood pressure. If the patient is very hypertensive, we may not see such a huge difference in gradient, and we may consider that patient doesn't have a severe aortic stenosis, and we will never refer the patient to the intervention. So these are all factors that we need to take into account when we diagnose. And then, how is the changes of the left ventricle in response to the pressure overload? If this is the normal geometry of the left ventricle with a relative wall thickness with smaller than this value and with a normal left ventricular mass, we will see that there are some patients that may respond with a concentric remodeling, so just increasing the relative wall thickness but still preserving the LV mass, or we can have a much more concentric hypertrophy where we have increased relative wall thickness and LV mass, or much more eccentric hypertrophy where it's much more dilated and perhaps a much more advanced stage of the disease. In this study, evaluating the development of severe aortic stenosis, you can see how the morphology of the left ventricle changes over time until they reach a status of severe aortic stenosis. And this is for women, this is for men. The normal geometry tends to disappear if there are less patients with severe aortic stenosis that preserve a normal geometry, but you can see that women develop much more a concentric hypertrophy, so this kind of hypertrophy, as I show you in the examples, while men, perhaps they still preserve much more a concentric remodeling or concentric hypertrophy, but in terms of eccentric hypertrophy, that will be the worst, is more or less the same between men and women. Also, this study, for example, similarly trying to understand in more than 1,800 patients, with 52% of them male and having from moderate to severe aortic stenosis, we can see that women, they develop much more concentric hypertrophy, so this kind of remodeling, while men have perhaps more favorable remodeling or response of the ventricle to the severe aortic stenosis. And in terms of the worst remodeling, that would be eccentric hypertrophy, there are no differences. How does that remodeling impact on the variables that we use to define severe aortic stenosis, whether there is aortic valve area index, peak velocity, or mean gradient, and then the parameters that are involved in the results that we get with the hemodynamics of the valve. So here, this is a complex graph trying to show the natural history of severe aortic stenosis, but the study what concludes is that women have a smaller aortic valve area than men when they reach severe aortic stenosis. They have a smaller body surface area that yields to a lower stroke volume, resulting in a lower aortic valve gradient than men, while men have a higher aortic valve gradient than women, with a less increase in aortic valve gradient from moderate to severe aortic stenosis due to a larger reduction in stroke volume. So these are trying to understand how this happens over time and if we could perhaps target patients earlier for a better outcome after aortic valve replacement. In terms of how to understand these differences on echo, CMR has provided more insights. Why? Because basically we can also assess the tissue characteristics. That myocardium is not only dilating or thickening, is also changing in terms of fibrosis. And this study coming from the group of Philippe showed that actually women show more extracellular volume fraction. That means that they have more fibrotic at the level of mild aortic stenosis, and these differences persist when they are moderate aortic stenosis and severe aortic stenosis, while the late gadolinium enhancement, which is the replacement, the amount of scar, let's say there are no differences. But inside, what we cannot see, CMR tells us that actually women have perhaps more interstitial fibrosis, which could lead to a more stiffer ventricles. There are other diseases that we need to keep in mind, and for example, this patient, one could say, is much more preserved the function in the apex of the ventricle. Are we missing something? Is this a cardiac amyloidosis? That's also that we are learning now in these patients with techniques such as strain imaging showing this apical pattern of preserved function in the apex while in the other areas are reduced, and with techniques of SPECT, you can also see that there is an uptake. Once the patients are treated with TAVI, in terms of mortality, there are no differences, but that's something to keep in mind if the patient doesn't improve in symptoms. As we said as well, the LVOT dimension or the annular dimension will impact on the calculation. It's very frequent that we see in these patients this kind of knee shape of the interventricular septum, and if we measure a little bit down, this ventricle or the annulus will be smaller, and that will lead to a smaller area. And then finally, the aortic dimension, which perhaps at the beginning is not going to impact that much in our selection, but later on for the follow-up of these patients is going to be impacting in terms of how we measure those gradients. If we have smaller aortas after the aortic valve or larger aortas, we may impact on the net pressure gradient that we can generate through the aortic valve. And if we don't take into account those factors, we may think later on during the follow-up that the prosthesis may be dysfunctioning when it's not. So these are also factors that we need to take into account. Once we have changed the valve, how does it respond in terms of LV remodeling? So basically, there are not many differences between men and women. They tend to reduce the volume and improve the ejection fraction, but to a similar degree. And in terms of the geometry that I was showing you, there are no differences at 6 months or 12 months between men and women. And this also is reflecting in the hemodynamics of the valve. Between men and women, there are no differences in terms of peak gradient or mean gradient at follow-up in this large study. So for me, the conclusions for this first talk, there are 6 differences in aortic stenosis. There are controversial data in terms of patterns of LV remodeling, although it seems that women tend to have a worse remodeling than men. Female patients have smaller left ventricles and stroke volume leading to lower gradients. Female patients have stiffer ventricles with increased filling pressures, and female patients have smaller LVOT, so that leads to a calculation of a smaller aortic valve area. And also they have a smaller ascending aorta, which may impact on the pressure recovery phenomenon. And after TAVI, similar valve hemodynamics and changes in LV remodeling are shown in male and woman, and therefore we don't have perhaps to treat differently in those cases. Thank you very much for your attention.
Thank you very much. So as I said in the beginning, we keep your questions for the end, but keep them because we have many discussions.
We're gonna have. So the next speaker is Philippe Pibaro, and while he's jumping on his slides, I want to thank Edwards again team for organizing this female-oriented session and not prosthesis-oriented session. This is very important. The objective is to increase awareness. And Philippe, this is what he's going to show us. It's that it's very important to understand the definitions in order to read any publications. Philippe?
Yeah, thank you, Tom. And yeah, so this is a broad topic, but I agree the definitions are very important, both in women and in men, of course. These are my disclosure. And this is the other disclaimer. So in VOC3, we really paid attention to well define the different type of bioprosthetic valve dysfunction. So you have the non-structural dysfunction, so any abnormality not intrinsic to the valve. So the valve is functioning normally, but there is a hemodynamic abnormality. This includes prosthesis-patient mismatch and high residual gradient and paravalvular regurgitation. But then you have the structural dysfunction. That is a separate category. This is the one that impacts durability. So intrinsic, irreversible, permanent changes to the leaflets. So the leaflets are abnormal, and this morphological deterioration is followed by an hemodynamic valve deterioration that is moderate at first and then severe. And then ultimately, you're going to have bioprosthetic valve failure. And so prosthesis-patient mismatch is really defined as a valve that is functioning normally, but it's too small for body size and so for cardiac output requirements. And these are the cut point of index airway that we use to define mismatch according to VOC3. And the main consequence of mismatch is the persistence of high residual gradient across the valve that is defined as a mean gradient more than 20. But I want to make sure that you understand that this mean gradient more than 20, because we'll come back on this, is just another expression or marker of prosthesis patient mismatch. So the predictors of mismatch that have been reported in the surgical and also now in TAVR literature, you often see, female sex is one of the main one, small annulus is the other main one, and actually there is a strong intersection between women and small annulus. Many of the women, 75% have a small annulus and vice versa. Having said that, I think, although I'm a big fan of echo, as you know, we have to keep in mind that echo may overestimate the gradient and underestimate the airway. And if you underestimate the airway, you overestimate the mismatch because of pressure recovery and assumptions we do with the Bernoulli formula that is ultra simplified. And with obesity, we may over-index the airway and so overestimate the mismatch. And the last but not the least, at least 40 to 45% of the patients following TAVR or SAVR are in low flow state. And if the patient is in low flow state and you measure the airway, it may be smaller than the normal value. And so this is a pseudo-severe mismatch. And to exemplify this, this is the Lytton trial that was led by my colleague and friend José Prodescabao. It's a self-expanding versus balloon expandable for a valve-in-valve within small failed surgical bioprosthetic valve. So it's a true small annulus context. And the endpoint was hemodynamics, and you see that the gradients were significantly higher by echo with balloon expandable versus self-expanding, also numerically, but not statistically, higher rate of mismatch. But if you focus on the bottom right panel, we did also a sub-study where we compare gradient by echo and invasively, and you see that although there was higher gradient by echo with balloon expandable, with catheter, the gradients were lower and not different between the two arms. So again, the small valves with a small annulus, especially the small balloon expandable valve, this is maybe where echo is overestimating the most the gradient compared to catheter. So to overcome this limitation of overestimation of mismatch by the airway measured by echo, we proposed 30 years ago, the predicted method. So the idea here, and this is the method that has been used by the vast majority of the SAVR series. So you take the normal reference value of airway for the exact model and size of valve that has been implanted and divide by BSA. So no measure, no probe needed to measure anything. It's a simple calculation. And you see that in this patient, there is still a mismatch with the predicted method, but it reclassified the severity from severe to moderate. And it's a more specific and more robust marker of true severe PPM, this predicted method. And you can find this normal reference value for TAVR in this paper that we did with Becky Ann some years ago. So in a partner two trial and S3I registry analysis, we compared with Julien Ternacle the predicted versus the measured method in this data set. And actually what we found is that the incidence of severe mismatch is markedly lower with the predicted versus measured AOI, both in the SAVR and TAVR arms. But regardless of the method, the incidence of severe mismatch was significantly lower with TAVR than with SAVR. And with regard to the impact on outcomes, well, in SAVR, there was an association between severe PPM by the predicted method and outcomes. But in TAVR, there was no association, essentially because there was the severe mismatch with the predicted method was almost inexistent. There was 0.1% incidence. This is a recent analysis, not published yet, it is in press, of the TVT registry in balloon expandable valve 20 and 23, showing here no association between severe mismatch or moderate mismatch by the measured method on the left or predicted method on the right and 3-year mortality. So, of course, it's midterm. We have to wait for longer follow-up and also see the impact on the durability. So if we come back to I would say to this dysfunction that really matters in terms of valve durability and outcomes, the structural dysfunction. So in VALV3, we try to be very precise on how to define it. There are two major criteria. First, you need to have morphological abnormality. The leaflets, you need to document some abnormalities to the leaflet. The leaflets need to be thickened, calcified, teared, whatever. And then the second criteria is the presence of hemodynamic valve deterioration. So it's not the mean gradient more than 20 or 30 at any echo that is important. It's more the change in gradient during follow-up. So you need to document an increase in gradient of at least 10 millimeters of mercury with concomitant decrease in AOA and or a new onset or worsening of at least 1 grade of transvalvular AR. And stage 3, same concept, but with more severe criteria, a delta of mean gradient of at least 20. So this slide is just to illustrate how important is the definition that you're going to use on the conclusion. This is the example of the CoreValve high-risk pivotal trial. And in this trial, to report the stage 2 and 3 SVD at 5 years, they used the European definition. That was the first definition to be proposed before VAC3, where here the criteria for stage 2 or more SVD is a mean gradient more than 20 at any echo or an increase in mean gradient more than 10. So if you only had the mean gradient more than 20 in a patient with prosthesis-patient mismatch, you would conclude, although the valve is functioning normally, this is a stage 2 SVD. And so if you use this criteria, you would conclude 24% of moderate or severe structural valve deterioration in the SAVR arm at 5 years. This is very high rate, right? And TAVR is a winner here, 9.2%. But of course, this is not the reality. This is overestimated. And if you use the actual VALV3 criteria, the rates would be much lower as expected at 5 years and similar between arms. And if you use reintervention, that is more the failure, because bioprosthetic valve dysfunction, I would say, does not matter for the patient. It's really the failure that is important, while numerically higher in TAVR. So you see, you get completely different conclusion depending on the definition you use. And I show you this case. A small balloon expandable valve here. The leaflets are normal. You hardly see the leaflets, they're moving well. So this is normally functioning valve, but the mean gradient is 26. So, and the AOA is 1.2, but which is normal for this valve because this is a valve that we use in very small annulus. And if you use the European definition, you would conclude that this is stage 2 SVD, although we are only at discharge, right? Whereas in fact, this is a pure severe mismatch, okay? So it's important. It's important given the context of the SMART trial recently published, where you had two, so it's TAVR, balloon expandable versus self-expanding in the small annulus. So 75% of these patients were women, and there were two primary endpoints. One was clinical, mortality, stroke, or rehospitalization at 1 year. The other one was bioprosthetic valve dysfunction, and there was non-structural valve dysfunction included, but there was also this hemodynamic structural valve dysfunction that was defined on the mean gradient more than 20. And this is my main concern with this trial, because here we call structural dysfunction a mean gradient more than 20. That is not structural dysfunction. So the results, I guess you know the results. There was no difference in the first primary endpoint clinical outcomes, but an important difference in the rate of bioprosthetic valve dysfunction in the small annulus as well in the sub-analysis of women. But this difference was essentially driven by the difference in the structural hemodynamic dysfunction defined as a mean gradient more than 20. And if you put that into perspective, this trial would conclude that 32% of the valve in the balloon expandable valve and still 10% in the self-expanding would be structurally dysfunctional at 1 year, whereas, for example, in partner 3, where we used the accurate valve 3, there was 0% of SVD at 1 year in both the SAVR and TAVR arm. That is expected, actually. You don't expect any SVD at 1 year. So I think it's important to keep in mind. And does this BVD still is a marker or a predictor of valve durability? Well, for the first year, we can say no, because if we look at the rate of bioprosthetic valve failure in the small annulus, it is 0.6% in self-expanding, 0.3% in balloon expandable. And if we add the early technical failure and crossover from self-expanding to balloon expandable, that would be more 4.6% in self-expanding versus 0.3% in balloon expandable. So differences, if you look at purely at failure, they are inverted versus what is predicted by the bioprosthetic valve definition. So in the paper from the SMART, I tried to find the VARC tree, the true VARC tree. There is one place that it's mentioned VARC tree, but it is SVD plus non-SVD, so it's difficult. So I tried to do some estimation and maths, and I estimated that, of course, may not be accurate 100%, but about 0.4% of the self-expanding valve versus 1.6% in balloon expandable valve would have a stage 2 or 3 structural bioprosthetic valve dysfunction, which rates that makes sense at 1 year, right? And this would not be significant between the two groups. And finally, I think, early hemodynamic performance does not necessarily predict valve durability. The surgeon in the room knows that very well. We have several bad experience. We've all been enthusiastic about the trifecta valve. First, me, I would say, because, I'm often called a mismatch guy. I don't think it's a compliment, but, I saw this trifecta valve and the gradients were great. The airways were great, very low rate of mismatch. So great early hemodynamics, but we know the durability was not good. And same with mitral flow, same with Toronto SPV, etc. So in summary, this is a summary of the results of TAVR versus SAVR for stage 2 or 3 SVD really defined on VARC tree, and you see that up to 5 years, there is low rate, below 4% in all trials, not different between the TAVR versus SAVR. Notion trial is the only one that made it to 10 years. Here, again, no difference between the two arms. You have to be careful with Notion because 65% of the patients were dead by 10 years, so huge survivorship bias. But still, no red flag for lower durability or shorter durability in TAVR. So female sex and small annulus definitely associated with higher risk of severe PPM and high residual gradient. Keep in mind that PPM and high residual gradient may be overestimated by echo, essentially because of the factors I mentioned. And the high residual gradient and PPM may be overestimated to a larger extent in the small valves, especially in the small TAVR valve and even more in the small balloon expandable valve. Severe mismatch is less frequent following TAVR versus SAVR, particularly in small annulus and particularly in women. And for now, there is no association between severe PPM or high residual gradient, which are non-structural dysfunction, and midterm clinical outcomes. We still need longer follow-up, but so far there is no association, especially in the TAVR series. An echo gradient more than 20 should not be considered as structural BVD. Actually, most of the time, in vast majority of the case, this will be more a marker for non-structural dysfunction for PPM. And so the valid definition of structural dysfunction must include evidence of structural changes. You need to document the changes by whatever modality you want. If you don't see well the leaflets by TTE, you can use TE or CT. And hemodynamic deterioration. So it's the change in the parameters that is more important than the absolute value of the gradient. And so there are some data that I did not show that link, non-structural dysfunction does not have link with outcomes at midterm, but structural does. It impacts outcomes. We have several studies showing that. And so the rate of SVD is similar and low in TAVR versus SAVR, so it's good news, but we still wait for more trials. And finally, early hemodynamic performance does not predict valve durability. So I think we need longer follow-up in the ongoing trials, and maybe also wait for the results of the future trials that will come out. And I like to advertise in particular the REIA trial, that is a TAVR versus SAVR in women only, and Hélène here is the one of the PI PI of this study. We expect to present the results at ESC this year. Thank you so much.
Thank you very much for this talk in the perspective of the result of the SMART trial. It's very interesting. So now we'll ask Dr. Wong to discuss about post-procedural gradients.
It's always hard to follow Philippe. Okay. So the major question is, do post-procedural gradients really matter in females post-TAVR? And are there any clinical outcomes or clinical impact for post-TAVR gradients? These are my disclosures. I have three main goals. Really, what are the baseline echo characteristics of aortic stenosis by aorta size and gender? And then discuss what is the relationship post-TAVR of echo gradients and mortality, because that's a big question that we all have. Lastly, I want to actually talk about risk factors for all-cause mortality post-TAVR in our patients. The number one thing that we all care about in this room is the patient outcome, not the valve, not the number, as Tomas was mentioning earlier, too. This is from the TVT registry data set from 2015 to 2023. When you look at male versus female baseline echo characteristics that are unmatched for native aortic valve, there is a difference between men and women's hearts. I've highlighted for you in yellow. The aortic valve mean gradient is slightly higher in female. But if you take a look at it, the left ventricle ejection fraction also is slightly higher in female. Women, as Dr. Delgado mentioned to you earlier, have smaller hearts, smaller volumes, potentially thicker hearts too. And then if you take a look at it, women are also more complex for valvular heart disease. The number of patients that have concomitant valvular heart disease, like mitral regurgitation and TR, is more common. Women are actually a higher risk population than men. But numbers sometimes don't actually do us justice for our understanding of what's going on. If I go into yellow and I show you the aortic valve mean gradient is higher in women, the LVEF is higher in women, of course the aortic valve area by calculation is going to be smaller. Sometimes it just might go in one ear and out the other. Let's focus on the images. Bottom left-hand image. If I showed you that heart, nobody would want that heart in this room. On the bottom right-hand, you want that heart because that has a really good ejection fraction. Well, that's what we're talking about, flow. You want a really good ejection fraction because that generates a really good flow and good velocity out the aorta. Well, the calculation for a gradient is actually the amount of flow and the force of the flow out the aorta, which is 4V squared. And that's what a calculated gradient is. So unless you want a low gradient on the heart failure in the bottom left-hand image, you're going to get a gradient that's good because that's how women are. They have strong hearts. More commonly thinking about it by echo. If you think about it on the bottom left-hand image, this is what the echo looks like too. Barely any differences for EF. Low EF, 50-55%. Bottom right-hand is a typical female heart. Typical female heart, hyperdynamic, small LV, hypercontractile too. This is why we have higher ejection fractions, higher velocities too, in a lot of stenosis patients. But this is not unique to us. You all knew this already. Most of us in this room have done transcatheter mitral valve replacements and mitral annus calcification. Dr. Mario Guerrero led the field in this, and we have learned in the past decade at EuroPCR from mitral 1, mitral 2, that in the baseline characteristics for TMVR and MAC, majority of these patients are unfortunately female. Majority of them have small hearts too. In red, majority of them also have ejection fraction over 60%. And guess what? Majority of them have LVOT obstruction and can't get a TMVR device. We all know this, so this is not new. Female hearts are definitely anatomically different. But what about the relationship for post-TAVR gradients and mortality? Because that's what's really important. This is the 3-year outcomes that Philippe had mentioned earlier. This is manuscript in Press. This looked at the TVT data set registry, and we actually matched the patients for 20 SAPIEN 3 small annuli versus any valve over 23 millimeters, and everything was cross-matched. As you can see in propensity matching, there was no differences in baseline characteristics in the patients with 20 SAPIEN 3 versus the patients that had 23 or higher for any kind of TAVR. What was also propensity matched was you saw baseline echocardiographic features for these patients, 20 and 23 or higher. There was no differences in baseline EF, baseline echocardiographic features, or AS gradients. What was important was that we found there was differences post-TAVR for numbers, specifically for ejection fraction and gradients, categorized as less than 10 millimeters of mercury, a gray zone 10 to 30, and then over 30 on discharge echo. The trend that was concerning was, hey, why are there 10 to 30s? Why are there over 30 gradients? What is going on? Should we be afraid of these numbers? But then I'm going to show you this arrow. and goes back to our EF data. Positive remodeling can happen, and the gradient numbers actually match the ejection fraction. The higher the ejection fraction, the higher the flow, the higher the calculated gradient by echo. It's velocity, it's flow, it's a measure of the heart function, heart muscle. Philippe mentioned this earlier. This is the Kaplan-Meier 3-year clinical outcomes for this manuscript in press for mortality, stroke, and mortality or stroke of 20 sapien valve versus anything bigger than that for balloon expandables. And as you can see, across all 3 Kaplan-Meier curves, there is no difference in all-cause mortality, stroke, or combined endpoint at 3 years. We don't have anything longer than that, but for now, that number is just a number. But what are the risk factors, and when should we get scared? Because these numbers do have something into it. And when should we be actually concerned? We should actually be concerned when the numbers are actually low. At first, you think that that's not right, because in the cath lab, we're always told a number is 0 when they do a pullback. Well, of course, because it's a pullback. It's not measuring the left ventricular force. What we found in the bottom left-hand image, as you can see, in blue is when we have ejection fraction less than 50% and a mean gradient less than 10, you have an increased trigger for mortality, an increased signal. And you can see in the far right-hand image, when you have ejection fraction less than 50%, and we have a mean gradient less than 10, so a low gradient and a low EF, for all-cause mortality and stroke, there's also a red flag too. This is not apparent for high gradients. However, if it's a high gradient patient that has a low ejection fraction, then there's a concern. All of this is showing us that a patient with a bad EF has worse clinical outcomes, but you all knew that already. So what about post-TAVR clinical outcomes in females? Because female hearts are complex. We looked at it by discharge mean gradient less than 20 versus greater than 20, a mean gradient, and their 3-year outcomes. And on the unmatched and the far left, you can see that when we have a gradient that's greater than 20, the actual survival is actually better. When the mean gradient is less than that, survival is worse. When we actually matched for it, it wasn't statistically significant, but there was still something like a trend. This was the most important slide. This spline curve will start with the bottom left and the bottom right-hand images, 3-year all-cause mortality by the differentiator. Now, less than 10 millimeters of mercury is on the far left, and you can see there's a hazard ratio. Between 10 and 30 is a sweet spot. We don't have a hazard ratio there. On the far right, greater than 30, there's a little trend of something again. If you think about it by common sense, when we look at our HOCM population, or if you think about it, all of you right now that are dehydrated after 8 hours of EuroPCR, most of us have a gradient of probably 15 millimeters across our normal aortic valves right now, and we would care less about it. But that's what this is trying to tell us in this spline curve. 10 to 30, it's okay. Over 30, we need to be investigated. You know, Tomas always teaches me something every time I talk to him. And Philippe mentioned this too. We might need to recalibrate our discussions because we as a community really are here for our patients. It's not about valve versus valve. It's not about 20 versus a 23 or vendors versus vendors. It's about what do we know? Unfortunately, this is a paper that was beautifully written in 2021, and it was ahead of the science, so it wasn't really published very much and publicized. It showed that, you know, echo is much more than just a number for a gradient. There's Doppler velocities, there's ejection fractions. And what Becky Hahn and the team found was that when Doppler velocity indexes are looked at for small surgical valves, they're actually predictive of bad outcomes. A smaller surgical valve with a lower DVEI actually has worse 2-year outcomes that you don't see with TAVRs. So instead of thinking about TAVR versus TAVR, we might need to think about TAVR versus SAVR in small annuli. So in summary, gender differences do exist in cardiac anatomy. Higher ejection fractions get a green thumbs up because that's a good heart, it's functioning. Post-TAVR, 20 and 23 sapien 3 were larger. Despite higher gradients, there was no 3-year difference for mortalities. And if I have a discharge gradient that's low, that's that bad heart. That's a heart failure. That's a thumbs down. And that's a concern for increasing mortality because bad EFs are worse culprits for outcomes. That's gender neutral, and we know all of that. And in conclusion, you know, we should really be having a discussion not so much about TAVR versus TAVR, but should we actually be considering SAVR in small annuli? Should we be putting a 19 millimeter in a female small aorta in the future or a short guy? I don't know. We have to have that discussion. Thank you.
Vivi, that's excellent as usual. Precise, concise, and beautifully said. The next speaker is the chair of the session, Professor Elchaninov. She's going to take us through the results reported after TAVR.
Yes, I will try to show you what do we have concerning studies of TAVRs or TAVR in female, and what is the future about the studies. So we know from a study that there is a potential undertreatment of women with aortic stenosis in Europe. You can see in the mid figure, in blue you have the men, in red you have the female, and you can see that the overall number of blue versus red demonstrates that there is undertreatment for female, whether it is TAVI or surgery. Women in dark red have more TAVI than surgery. The dark color is the TAVI and the light color is the surgery. But overall, we can see that the rate of treatment for women is lower than in men. Second, there is also another study which is interesting. We know that probably women are undertreated, and we know from this study, which compares observed survival to expected survival in a matched population of the same age, but those with aortic stenosis and those without aortic stenosis, you can see that female have excess mortality at 5 years versus men, even after age matching, again, probably because they are undertreated. We know also that we have gender differences in outcome after TAVI. We know that they have higher rate of complications. You see here you have the female in blue. You have a little more stroke, more major bleeding, but mortality is smaller, is lower, and in fact they have a better survival than men in this Italian trial. So it's something which is quite difficult to understand, but they have a better outcome on follow-up. If we look another study evaluating SAPIENS 3 at 4 years, in women and men using transfemoral approach. Here there is a trend toward lower mortality in women at 4 years, even though it's not statistically significant. But there is something about lower mortality after TAVI at 3 and 4 years in women versus male. When we look at partner 3, which is randomized, so it's a strong evaluation comparing surgery to TAVI, to SAPIENS 3, we have interesting information. We see that the difference between surgery and TAVI is more important in women than in male. You see that the primary endpoint is lower in after TAVI than after surgery. So the women seem to benefit more from TAVI than from surgery, and in the male, there is the difference is lower. So the benefit appears more clear in female with TAVI than in men. When we look at the other valve, the core valve, they have the evolute low risk at 3 years. Here, it's not so clear. It's quite the opposite. I mean, there is the numbers are quite similar, and it's not clear that TAVI is superior versus men. That's why we have a lot of questions which are not solved in women versus male who are treated for aortic stenosis either by TAVI or by surgery. That's why the REIA trial has a very important place, because it's first randomized research in women with aortic stenosis. The scientific rationale is to answer the question, is TAVI compared to surgery non-inferior or even superior treatment option in women with severe aortic stenosis? Because recent data show, as I showed you previously, there is a potential reduction in the risk of death for female versus male undergoing TAVI, but it's just a potential reduction. There is an increased risk of death in female undergoing surgery, so surgery could be worse for female than in men. We know that women have differences with men in baseline and in procedural characteristics. And that's why it was decided that there was a big need for a randomized clinical trial to confirm the benefit of TAVI over surgery in female patients. So this is the objective of the REIA trial. So as was said, we are the principal investigators with DJ Cheche. It is the first female-only randomized trial in severe symptomatic aortic stenosis. It's the first and only randomized trial with SAPIEN 3 or Ultra in Europe against surgery, because you know that partner were done in the United States especially, and its first trial to include all comers irrespective of surgical risk. So this is the trial, the study design, which was published. So it's an investigator-initiated multi-center international randomized trial to evaluate safety and efficacy of TAVR versus surgery in female with severe aortic stenosis. More than 400 patients, 12 countries, near 50 centers. And female patients with severe AS are randomized between TAVR and surgery, so they need to be feasible by the two techniques. And we had the endpoint, the clinical efficacy composite endpoint at 1 year, which is the same as Partner 3, all-cause mortality, all stroke, and rehospitalization. We have additional combined endpoints. This is a very well done methodology with a screening procedure, post-procedure, discharge, 30 days, 12 months, echo core lab, etc. And so the study, the recruitment period is over. The last patient was treated last year, and the last patient completed the trial in April 2024, meaning we can have the results for, as was said, for the ESC, we hope, and the publication of this trial with, you see, 440 patients randomized. There was a kind of small delay because of the COVID, but I think we are all expecting the results, and we are very anxious about the result of this first randomized trial in female. So thank you for your attention.
Thank you, Ellen. I hope all these presentations will generate a lot of discussion with you. Please share your thoughts with us. I know this is a very hot topic. Philippe.
Yeah, sure. I think the issue with gradients is important. What Didi presented, I think, because we insisted a lot that high gradient may be bad, and we know that from obviously the native AS, and as shown by Didi, a very high gradient even in bioprosthetic valve when it's getting more than 30 and 40, it is probably concerning. But when you have a low gradient, it's not necessarily good news. As I always say to my fellows, if you have a severe stenosis, native or bioprosthetic valve stenosis with a very high gradient, and you die, I can ensure you that the gradient will be back to normal, will be perfect, will be zero, because there is no more flow across the valve. We always have to keep in mind that the gradient is highly flow dependent. From a fluid mechanics, it's a square function of flow. So when you have a very low gradient, it's not necessarily good. It might be a marker for low flow state and LVF. And this may explain these counterintuitive findings where actually, yes, there was an association between gradient at discharge post-TAVR in this small balloon expandable valve, but it was the opposite from what we would have expected. It was the very low gradient that were associated with increased. So I think it's an important thing to keep in mind.
If I can make a comment about, in general, I think we should always keep in mind that in clinical trials and investigations, when we deal with surrogate endpoint, a general rule, but very important, is that it is necessary first to demonstrate that the surrogate endpoint correlates with the outcome. And while we know many things about surgical bioprosthesis, as you showed, this is not true for TAVI. We don't have so clear relationship between the gradients, and you showed very well that this apparently does not correlate with prognosis. So even in designing and interpreting the trials, we should keep this in mind and before clarifying what is the true relationship. So this is point number one. So be very cautious in making conclusions, drawing conclusion with surrogate endpoint. And so the clinical endpoint should stay as the most important. And the second that also is in the same direction is clearly that what we know about the relationship between the gradient and the area and so on are based on the assumption that we are dealing with either native valve anatomy or with anyway round shape surgical prosthesis. And we in TAVI this is often not true. So this is something that intricates more the assumption that we do with velocity, the relationship between velocity and gradient. So again, it's I think there is a lot of knowledge that we still need to have in the interpretation of the function of TAVI.
Yeah, but Francesco, this is why we do randomized trials also, to try to put everybody on the same page. I have a question here that's coming from the audience. This is what the most important thing. And then I'll ask you one. Is there any data that shows that low gradient is connected with bigger remodulation of the left ventricle? You want to take this, ladies?
Well, that's a very good question, and I think that following the discussion that we are having, we are used to have always operated patients that have symptoms. So this is why I put the spectrum of the disease with 4 examples. We have focused very much on having the improvement in survival, making sure the treatment is safe, and we have evolved from surgery to transcatheter, starting for patients that were inoperable, then higher risk, intermediate risk, lower risk. But we don't focus on how we want the patient to look back when it's operated. And it's the first heart that I show. I want to have this heart when I change the valve. So a much more remodeled left ventricle dilated with poor ejection fraction is going to give a low gradient, but a remodeled ventricle with a small cavity as well. And we have seen many times, or at least I remember many times, a small woman with an annulus of 20 or 19 that the surgeon is going to implant a 19 valve that has a mean gradient of 20 will tell you why I'm going to change the valve. It's going to have the same gradient.
That's true.
And the woman were not being referred or were not being operated. Now that we have data with other valves that give better hemodynamics, I think that we have been focusing much more on how the valves last. But again, I think that we need to have the focus on diagnose the patient properly, look at the ventricle, look at the effects, and look how you can reverse all that with a proper valve.
You know, this gradient thing is a double-edged weapon that, as a surgeon, I've been living for a lot of years, and you know this very well. So we have to manipulate it with a lot of care. Didi, Philip was showing us that, I mean, everybody is debating about gradient, and the best way or best thing should be to look at the EOA. So why don't we stop looking at the gradients and just calculate EOA? And especially you've said hemodynamic gradients are lower, gradients on echo are higher, but we follow the patients on echo?
You know, a traditional echo report that's well done is 2 pages long. And a gradient is probably just 1 sentence of that 2 pages. I know that for Philippe and Victoria's reports are going to be 3 pages long, and I will love them. So I think back to Francesco's comment earlier, thinking about a focal point of a gradient is not wrong, but we're smarter than that. No pun intended. But, you know, we can actually think about other things. Unfortunately, in the TVT registry, and a lot of times when we start registries, we don't know as much as we know now. We're all evolving and we're all learning. That's why we're all here. LV cavity size, I don't believe, is actually captured in the TVT registry. So we really couldn't account for that. And even then, how do you grade LV cavity size? In the mitral and tricuspids, we to include LV and RV size, but we don't have that. So even though we see the positive remodeling and the heart shrinking back to normal and becoming vigorous and pumping great again, our only marker was the gradient. But there's 2.5 pages of information that would be very valuable that could actually help us understand more that we all see. But if we focus on that one number, we miss the whole forest.
Yeah, I think, the reason why we use more the gradients and report more the gradients because it's easier and more reproducible to measure than the airway. That is more challenging. But we have the DVI that is a kind of simplification of the airway that may be used. But I think the important question now I think we have to ask is, what do we do with these women with severe AS? What is the lifetime management? And I can give you my perspective, but I think in terms of, first, TAVR versus SAVR. I think we have now more and more data suggesting that TAVR may be associated with better outcomes compared to SAVR in women in particular. In men, this is not maybe not as clear, but in women, all the sub-analysis of the trial have shown that, in women, TAVR is superior to SAVR. Of course, we need to wait anxiously for the results of the REA trial with the definitive trial for women. And then once you decided TAVR, then the big question, self-expanding versus balloon expandable. I think, to me, with the data that we have, both platforms are equivalent with some advantages and disadvantages. Balloon expandable, yes, have a more higher residual gradient and severe mismatch, but self-expanding generally have more pacemaker, PVL, and stroke. So I think we have to individualize and we have to wait for longer follow-up data. And we also have to look beyond the early hemodynamics and the valve durability and also access to coronary arteries, which is in this population, the women with small annulus, small sinuses is an important consideration, the access to coronary arteries. So the choice of the first valve should also take into account this aspect. What do you think, Hélène?
No, I wanted to thank you because I think it's the best conclusion we could have for this very interesting session because it's hemodynamic, it's a very, very complex subject. And as you said, we have several parameters we have to enter in the discussion when you decide to treat a patient. It's not only the gradient, it's exactly what you said. The procedure has to be safe and you have to take into account everything. So, and we are expecting the results of the REGAL trial, which is it's a very exciting phase of the research in this TAVI era. So I wanted to thank all the participants for being here tonight, all the speakers, the moderators, and again the Edwards Company to have organized this very interesting session. Thank you.